thing is working now. So, okay, so I want to talk about long COVID and sleep. I think it's not a topic to snooze on, but there's not much known. I want to do an Indigenous affirmation on behalf of CSS and the university to pay respect to the Algonquin people and to acknowledge courageous leaders, past, present, and future. I don't have any disclosures to declare, but I do want to emphasize that I am a psychiatrist by training with subspecialty training in sleep medicine and addiction psychiatry. So I do not have any infectious disease background, which I think is required in some ways for understanding long COVID, but I hope that's a good thing and a bad thing in a way too. So I have to delve into this and go outside of my comfort level and try to understand this from a different kind of perspective than how a lot of other people would look at this. So I want to describe the post-acute COVID-19 syndrome, call it PACS. This is also called long COVID, post-COVID-19 syndrome. It has a lot of different names, long haulers. We'll just look at what symptoms are and effects in the world. I want to evaluate some theories looking at long COVID, including the development of a hyperinflammatory and hypercoagulable state. Look at some sleep symptoms associated with this and parallels with some other medical conditions, including chronic fatigue syndrome, fibromyalgia, and postural orthostatic tachycardia syndrome. So I'll just call that POTS for now, and CFS and FM. And then evaluate potential, and maybe I should have underlined that and bolded that because I only say potential utility of pharmacologic options that we use for sleep for long COVID, but may have potential for benefits for some long COVID symptoms. Okay, so first, long COVID, what is it? This was a newscast done in December of 2022, so not that long ago, talking about long COVID and
it has been more than 2.5 years since the first reported COVID cases in the United States. For some who have contracted COVID, the illness came and went. But according to the CDC, a range of symptoms still linger in nearly 1 in 5 American adults.
According to the CDC, 1 in 13 adults in the United States have had long-lasting COVID symptoms. The so-called long haulers have cleared the initial infection, but are left with symptoms that can last weeks, months, or even years. The symptoms of long COVID can affect different parts of the body, like the lungs, the heart, or the brain, according to the National Institutes of Health. The most common symptoms are fatigue, fever, respiratory problems, heart palpitations, digestive issues, and post-exertional malaise, meaning that symptoms get worse after physical or mental effort.
Some of the difficulties we have right now is, as physicians, we don't have good tests. We don't have good biomarkers. So it's been 2.5+ years. We still don't have something where we can definitively diagnose it.
Most people also report neurological problems, brain fog, headache, dizziness, pin and needle feelings, and sleep top the list. In many cases, the symptoms can be persistent and extremely debilitating. Even for physicians, long COVID is still not well understood.
In some cases, patients have been left bedbound. There's a large number of people who are applying for disability right now. It's probably the #1 diagnosis for people applying for Social Security and disability.
So I just want to highlight 2 things that I really caught there with their description. One, they couldn't agree on what the prevalence of long COVID is in the population. You heard the lady say 1 in 5, and then later the CDC says 1 in 13. So this is actually an issue because it's difficult to define. And then from a sleep medicine perspective, my other thing that I keyed on, sleep problems made that list. And so that made me wonder, is there potential for sleep interventions to help with some of those issues that are identified in long COVID? But I want to hear, I want to present a little bit about a Canadian perspective on long COVID. So
it has been more than 2.5.
And we'll get to that in a moment. So, but just to kind of understand how long COVID might occur. So this is a kind of a hypothesized pathophysiology of long COVID, that there's probably something in the host, that would be us, maybe some genetics, some predisposition in terms of medical factors or problems with our immune system, that when we get infected, we can have a range of responses to that infection. Now, the worst one would be death. And the most common one is the disease resolution and generation of prolonged immunity. So yes, probably at least 80–90% of people will go that route, but a small percentage of people, but again, it depends. We don't even know what percentage that is. It will be anywhere from 10 to 40%, or two to 40%, depending on when people were infected, will have a slow or abnormal infection resolution with prolonged symptoms that can either lead to severely damaged organ systems and chronic health conditions, or maybe this long COVID, which it's the best and the worst illness. It's the best illness in the sense that it doesn't kill you. So that's really good. So it's not measured in terms of mortality statistics. On the other hand, it's the worst illness because it can make you, depending on the severity of the problem, quite debilitated, but people, they look fine. If you see them, sitting here or whatever, they'll look okay. You can't tell that they have it, but it can dramatically change their life. And so this is living with the COVID, and that's some of the issues and challenges that we have to deal with. So what about the patient experience? As I said, the Canadian experience. So this is a CBC story from last year, but I think many patients are still suffering now with this in Canada.
Candace, I'd like to start with you. Can you share with us when you first realized that your COVID was long-haul COVID?
Sure. So when I initially had symptoms in March of 2020, COVID wasn't even on our radar. I hadn't traveled. I was showing mild symptoms. I went to the doctor, and I seemed to recover quite quickly. I was able to continue on with my daily life and didn't think too much of it. It was a few months later when I was hit with the same symptoms, but much more severe, along with a host of other symptoms that affected my whole body and eventually couldn't work. It was then that I started to realize that it could have been related to COVID when I was hearing about other people with the same types of issues and symptoms.
And if we think back to March 2020, I mean, this was, long before the vaccine was available. How are you now?
Honestly, there hasn't been much improvement over that year and a half plus since I've had the long haul symptoms. I'm still struggling, extremely fatigued. My husband has to do all of the housework and the cooking. I'm still not back to work. It's been a long haul, as they say.
Yeah, no, it sounds like it. Adriana, can I ask you the same questions? When you first realized that you had a much bigger problem on your hands than expected, and also how you're doing today?
Yes, I got sick in December 2020, and unlike Candace, unfortunately, I never actually recovered. It was, the doctor said, it's COVID, you should just let it run. 10 days, you'll be fine. And, 10 days went by and I wasn't improving. I was going at least twice a week to the ER because of my oxygen was low, my heart rate was through the roof. I couldn't even move. When the end of January hit and I was still very sick, like I knew obviously there was something very wrong, and I didn't know what to do at that point.
And here we are, a year and several months later. Has your condition improved much, if at all, since then?
The only thing that's improved has been my lungs, because I've been doing daily lung therapy with a specialized COVID lung specialist. And it took me about 10 months, almost 11 months, to be able to laugh without having a coughing fit.
Wow.
Other than that, everything else is the same. My cognitive function actually has been declining. My brain function, I've always had very bad brain fog, and now it's actual neurological damage that they detected. My brain function again is going down. My heart is still very bad. I still get 120, 160 heart rate out of the blue, and that's in 2 different medicines for the heart.
Wow. Dr. Bogosh, what do you think? A lot of people are going to be listening to both Candace and Adriana in this age of variants and subvariants and thinking, could this happen to me? I mean, what's the answer?
Yeah, I mean, it's obviously awful to hear, and we hear more and more stories like this, and everyone seems to know somebody that has chronic symptoms after COVID. One of the issues, of course, is the data that we have to date. And, this is being studied increasingly, but there's a lot of room for improvement in some of the clinical studies that we have. Some of the studies don't fully define the issue. There's limitations because some of the studies don't have control groups, or they have reporting biases, or there's a non-standardized definition of what long COVID is. But you've heard, of course, it's real, it's here.
Candace, how has your life changed?
It's changed almost 100%. My days are spent just managing symptoms. I can no longer exercise. I'm having issues with my legs, pain and muscle spasms. Like Adriana said, I'm having cognitive issues as well, finding it very difficult to read and watch TV. So most of the day I just lie in bed. I can listen to audiobooks and that's it.
Candace, it strikes me that it's not every day that you have an opportunity to actually speak with an infectious diseases specialist. I'm curious, do you have a question for Dr. Bogosh?
I do. I'd love to know, is there hope for long haulers in the future? And how is the research going in Canada as far as trials for drugs and for treatment?
Yeah, there absolutely is. There is hope. And it's not just in Canada, it's around the world. I think it's increasingly recognized that long COVID is a serious problem. And as we heard at the very beginning, there's more attention paid toward this by both federal and provincial governments. And in fact, there are clinics popping up that are really geared to support individuals who are suffering from chronic symptoms following a COVID-19 infection.
Right. So hopefully
Candace,
that ends on a little bit of a positive note. So just to review, long COVID has a lot of different names in the scientific community: post-acute COVID-19 condition, post-COVID syndrome, chronic COVID syndrome, long haul COVID-19, post-acute sequela of SARS-CoV-19. So this is part of the problem, right? They can't even agree on a name for this condition, let alone sort of a definition for criteria. And all these terms are used kind of interchangeably. I'm just going to call it long COVID from now. I feel like that's the most convenient for the public to kind of recognize. So this is kind of a complicated slide, but just shows what we kind of understand about how long COVID may occur. So the COVID virus is right here, this little gray molecule with the red specks, and it's supposed to bind to cells, what are called endothelial cells, or cells of the tissue, via a receptor called the ACE2 receptor. And then through the ACE2 receptor, that's how it's supposed to enter the brain. And so it's thought that that pathology might be how it causes some of the central nervous system symptoms associated with COVID, like the brain fog and mental fatigue. But it also infects the white blood cells. Those are our cells that kind of fight infection, and through mechanisms that are not clearly understood, activates an excess inflammatory response from the immune system. And so this might be another pathology by which long COVID emerges, that for some reason our immune system just doesn't shut off the way it's supposed to. And so not only does it attack the COVID virus, but it also affects other cells in our body, because it's like kind of having a military and invading a territory, but also killing the innocents along with the bad guys. So there might be just too much damage occurring there. But then a kind of a side effect of that inflammatory response is that those cytokines start to break down platelets, and platelets are the things that we have in our body that make clots. And so if those platelets start breaking down or start getting damaged, then those platelets can start to gather together and form extra clots in our blood. And it's thought that those little extra clots, microclot formation, might also be responsible for some of the long COVID symptoms. So these are some of the theories right now about how long COVID emerges or develops. But again, they're all just theories at this point, and it might be a combination of all of these, one or all of these factors too. So again, a definition is really complicated, but the World Health Organization and FACT, Public Health Agency of Canada, they define long COVID as symptoms that persist at least 3 months after an initial COVID infection. There's over 200 symptoms that are identified. So, that makes it really hard to make criteria for that. Early in the pandemic, up to 40% of people who were affected with long with COVID, we're actually having persisting symptoms. But now with changes in variants and increasing vaccination among the population and overall development of population immunity, newer studies are suggesting that that prevalence might be 2 to 5% of people who are infected. So still a substantial number, but it's a moving target, right? Because it depends on what variant you're infected with and whether you're vaccinated and what vaccine you got. And these things are all very difficult to control in studies. So this is why the prevalence just changes all the time. But nonetheless, with where we're at now, recent estimates suggest that long COVID may affect up to 65 million people worldwide, including 1.4 million Canadians. So just to put that in perspective, I think the closest city in Canada that I think Calgary has like 1.3 million people. So just imagine every single citizen in Calgary being affected by this. That's how many people are affected potentially by long COVID. That's a staggering number of people. So there is some good news as Dr. Bogosh hinted at. So one is that newer data suggests that our vaccinations are likely protective from developing long COVID. So that's why the prevalence is probably dropping now compared to what we saw, especially early in the pandemic. And the vast majority of people actually do improve within a year of symptoms. A very powerful Israeli study that followed long COVID patients for a year and showed that, again, most patients will actually recover from these symptoms, but it might take a year. But that's a painful year then in that time potentially, but it's still not everybody. So the causes for this, I kind of reviewed this earlier, but it might be that the virus is just persisting in the blood, that the immune system doesn't fully get rid of it. As I kind of mentioned, maybe a hyperinflammatory condition because our immune system is just hyperactivated against this and starts attacking other cells. Microclot formation. So because of damage to the platelets indirectly related to the immune activation, that these clots start clogging up other areas of our body, leading to the weakness, the fatigue, and perhaps the brain fog. Another theory that has gained some traction is that there might be reactivation of some latent viruses like herpes viruses or Epstein-Barr viruses. So these are the viruses that are responsible for illnesses like mononucleosis. So people who get mono, they feel really fatigued, and it might be that with COVID, many people will carry these viruses and they don't do anything, so we never think about them. But we know that for people who are immune suppressed or have some issues, these viruses can come up again, even after being dormant for decades. And with long COVID, they might also be part of the pathology as well. So again, this is just another slide kind of explaining some of that mechanism and where the long COVID or the viral issues may impact the body. So the immune dysregulation leading to persistent infection, this can affect the gut, the gastrointestinal tract, and also kill some of our healthy gut bacteria. That might play a role in some of the symptoms. And then the blood clotting, which is a very, I think, tantalizing narrative. And then also because the long COVID may penetrate the CNS system via the ACE2 receptor, that might compromise the neurological signaling and lead to the CNS symptoms like the brain fog and sleep symptoms. So, but you heard that sleep symptoms are, kind of very common among long COVID patients. So I'm like thinking, well, could sleep play a role and is there an option? So I think the first thing to think about is what does sleep do? And I don't know if people remember Kawhi from the Raptors championship, but he always liked to say, what it do, baby? So what does sleep do? Well, the bottom line is we don't really understand actually, but sleep clearly has some kind of restorative function, right? If we don't sleep well, we know that we feel more tired in the day. It probably plays a role in energy conservation. All of our metabolic processes slow down in sleep. It also plays an important role in immune function regulation. So this is tantalizing with respect to long COVID. There's something called an ontogenetic hypothesis, which suggests that sleep plays a role in maturation of CNS cells. I don't think that's really relevant here. It's important for memory consolidation. So for any students here, we know that people who pull all-nighters, they tend not to do as well on exams compared to people who actually sleep the night before. But when people with long COVID are complaining of memory problems, maybe part of sleep is compromised, and that might play a role in some of the memory issues that are associated with long COVID. And a very new theory that has come out but very tantalizing again with respect to long COVID, is that we know sleep plays a role in waste clearance. It clears various proteins from the brain, including beta amyloid and tau, through a system called the glymphatic system. Beta amyloid and tau, if they accumulate excessively in the brain, that's thought to be the hallmark pathologic findings for Alzheimer's disease, which is a neurodegenerative condition that significantly impacts memory. So I want to show a brief video by Jeff Elliott. So he is the guy who's largely credited with discovering this glymphatic system. This is from a TED Talk that he had done.
Sleep. It's something we spend about a third of our lives doing. But do any of us really understand what it's all about? See, we all know based on our own experience that when you sleep, it clears your mind. And when you don't sleep, it leaves your mind murky. But while we know a great deal more about sleep now than when Galen was around, we still haven't understood why it is that sleep, of all of our activities, has this incredible restorative function for the mind. So today, I want to tell you about some recent research that may shed new light on this question. We found that sleep may actually be a kind of elegant design solution to some of the brain's most basic needs, a unique way that the brain meets the high demands and the narrow margins that set it apart from all the other organs of the body. So how then does the brain solve its waste clearance problem? Well, that seemingly mundane question is where our group first jumped into the story. And what we found as we dove down into the brain, down among the neurons and the blood vessels, was that the brain's solution to the problem of waste clearance, it was really unexpected. It was ingenious, but it was also beautiful. Here, we're again imaging into the brain of living mice. The frame on your left shows what's happening at the brain's surface, and the frame on your right shows what's happening down below the surface of the brain within the tissue itself. We've labeled the blood vessels in red, and the CSF that's surrounding the brain will be in green. Now, what was surprising to us was that the fluid on the outside of the brain, it didn't stay on the outside. Instead, the CSF was pumped back into and through the brain along the outsides of the blood vessels. And as it flushed down into the brain along the outsides of these vessels, it was actually helping to clear away, to clean the waste from the spaces between the brain cells. If you think about it, using the outsides of these blood vessels like this is a really clever design solution. Because the brain is enclosed in a rigid skull, and it's packed full of cells. So there is no extra space inside it for a whole second set of vessels like the lymphatic system. Yet the blood vessels, they extend from the surface of the brain down to reach every single cell in the brain, which means that fluid that's traveling along the outsides of these vessels can gain easy access to the entire brain's volume. So it's actually this really clever way to repurpose one set of vessels, the blood vessels, to take over and replace the function of a second set of vessels, the lymphatic vessels, to make it so you don't need them. And what's amazing is that no other organ takes quite this approach to clearing away the waste from between its cells. This is a solution that is entirely unique to the brain. But our most surprising finding was that all of this, everything I just told you about, with all this fluid rushing through the brain, it's only happening in the sleeping brain. Here, the video on the left shows how much of the CSF is moving through the brain of a living mouse while it's awake. It's almost nothing. Yet in the same animal, if we wait just a little while until it's gone to sleep, what we see is that the CSF is rushing through the brain. And we discovered that at the same time, when the brain goes to sleep, The brain cells themselves seem to shrink, opening up spaces in between them, allowing fluid to rush through and allowing waste to be cleared out.
So this makes sleep essentially like a dishwasher for the brain, clearing out all these waste products. So what about sleep and long COVID? Well, again, reports are quite varied, but I'd say 25 to 78. So I think like half of patients at least will report sleep problems. The primary ones are insomnia and daytime sleepiness. Persistent sleep problems in COVID-19 patients actually predicted the development of long COVID in up to 3/4 of patients. So some people have advocated that maybe persistent sleep problems could be used as a biomarker for this. We actually heard yesterday there's some very recent data suggesting that people who are short sleepers might be more vulnerable to developing long COVID. So that might be an avenue of potential intervention. What's also really interesting to me is that the cognitive deficits that are described in people with long COVID, they're very similar to the deficits that you see with people who are sleep deprived. So there's deficits in reasoning, processing speed, memory. And again, you see those same issues in people who are sleep deprived. And we know that people who are sleep deprived, we see increases in inflammatory markers like interleukin-6, which is also seen in long COVID and several other ones, but I just highlight that one. So what about some similar conditions to long COVID? Very similar to many overlaps in symptoms with chronic fatigue syndrome or myalgic encephalitis, just CFS, ME, fibromyalgia, and postural orthostatic tachycardia syndrome. I'm just going to call that POTS from now on. So the features of CFS and ME, they're really varied, but if you look at it, it looks pretty similar to long COVID, right? Fatigue, the post-exertional malaise. So this is different from just getting tired after working out. This is even after like a brief activity, a few minutes, being totally debilitated the rest of the day. So it's quite different. And you see sleep dysfunction, autonomic manifestations, pain, neurological problems, changes in hormones leading to sweating, and then immune manifestations as well. So just a whole host of symptoms that are associated with CFS, but again, very high overlap with long COVID. In terms of definitions, this is supposed to have a six-month history of fatigue and exhaustion. Theories for CFS, probably from some viral infection, thought to be related to chronic immune activation or neuroinflammation, or even intracranial, that means in the head, hypertension. And so some theories have even postulated that maybe CFS is partly related to impaired lymphatic drainage, and there's some data to support this. So that is very tantalizing with respect to sleep. If you imagine, like as Dr. Elliott said, all those vessels normally contract to open the spaces up between the cells so CSF can flow between them. If they're not contracting in sleep, or if they're stuck together, then maybe this is why we're not getting that drainage. It's like not getting the dishwasher to operate properly because you closed off the water. Then you can't flush out those waste products. So if you look just at the criteria, up to 50% of patients with long COVID will actually meet CFS criteria, but it's difficult because it's difficult to define. So there's another condition that's been compared to long COVID called fibromyalgia. Cardinal symptoms of this are pain, stiffness, and fatigue with the various tender points in the body. So this is a chronic debilitating pain occurring in at least 11 out of 18 tender points, along with generalized pain occurring for at least 3 months. Again, 30% of long COVID patients will meet FM criteria, and 50% of CFS patients actually meet FM criteria. So some people think that this is all the same illness, maybe. Causes for fibromyalgia, again, not really well known, but maybe changes in pain receptor activity, maybe, again, excess immune activity and inflammation. We're hearing a common theme here among these illnesses: FM, CFS, long COVID. So, I got the same slide there. The other one that's very commonly compared to long COVID is POTS. So this is a feeling of it's a problem with autonomic dysfunction, where people often especially if they go from lying to standing, they'll find a sudden spike in their heart rate and potentially drop in their blood pressure, and their heart rate can spike intermittently during the day with no known cause, much like the long COVID patient described in the video that I showed. They often can have fainting episodes as well, and a whole host of other symptoms that you can see here. again, significant overlap with the long COVID symptoms. So, but a very formal definition is a sustained increase in heart rate of at least 30 beats per minute within 10 minutes of standing up. So normally our heart rate shouldn't go up that much, but without the drop in blood pressure. So blood pressure won't drop, but you have this excess heart rate. And then often in the day, patients with POTS, they have a lot of lightheadedness and weakness and fatigue. Up to 2/3 of long COVID patients will actually have autonomic dysfunction. So people have been intrigued by the overlap with POTS and long COVID. And then another issue that most patients with long COVID will have is maybe not necessarily the full POTS syndrome, but orthostatic intolerance. That is that they get more of their symptoms when they go from lying to standing. And again, 30% or more of patients with long COVID and CFS-ME will actually have these symptoms as well. So what about sleep findings in long COVID? They're actually very sparse because not many people are looking at sleep for patients with long COVID. They're just looking at them in the day, but not necessarily looking at what they might have at night. But some things that have come out a little bit or maybe tantalizing, some circadian disruptions, restless leg syndrome, and something called alpha delta sleep, which I just talked about. So for circadian disruptions, there are some findings suggesting that the circadian cycle, which is our regular day-night cycle, might be more unstable in patients with long COVID. This is based on accelerometer data. So these are people who are wearing essentially Fitbits, showing that there's actually a shift in their sleep schedule. And it's thought maybe that circadian instability might contribute to fatigue and some of the cognitive disturbances. Just think if you do shift work, you're going to, you might have some of these symptoms. And we see that RLS symptoms might double in patients with long COVID as well. Kind of like the lady we saw in the video there. It's very similar to restless legs syndrome symptoms. So the alpha delta sleep is kind of interesting. So I just want to talk about this briefly. So if we look at brain waves in sleep, if we see brain waves that look like this, we know that that person is awake at that moment. So we call that an alpha pattern. It's kind of a high frequency spiky pattern. And if we see brain waves that look like this, kind of slow, broad, bigger waves, we know that people are in deep sleep. So we call that delta pattern, but it's deep sleep. But what we see in some patients is a pattern that looks like this. So I don't know if people can see what I did there, but I tried to superimpose the top pattern onto the second pattern to make the third pattern. Like it's just a combination of the two. And so this finding is called alpha delta. This is very poorly understood, but we know that patients with this finding, their sleep is usually non-restorative. It's thought to be a hypervigilant state, very strongly associated with pain, fatigue, and anxiety. Seen, depending on the study, in up to 100% of patients with CFS, 70 to 100% of patients with fibromyalgia, and only one study I could find in COVID-19 survivors, they actually identified 80% of patients were having this finding. Now, that was only one very small study, but people are not looking at this, but it's interesting that there's also this overlap in these symptoms. So anyways, with that, I just want to review some treatment options that I think could be considered from a sleep medicine perspective. I want to emphasize none of these have been really well studied. They're only theoretical options, but I feel like we need some theoretical options to consider, but these are all hypothetical, but with some basis and rationale. So I want to highlight melatonin. So this is a normal hormone that we all have in our bodies that controls the circadian sleep-wake cycle. But people have done artificial intelligence reports where they asked artificial intelligence to scan everything that we have in terms of agents we use and see what agents have potential to help with long COVID. So as you know, this is a dietary supplement. There are issues with quality control, but I will say for those that care, like this particular brand has been identified as a good brand, the Weber brand, so I put that specifically here. From a sleep medicine standpoint, we use this to treat something called REM behavior disorder and also circadian rhythm sleep-wake disorders like shift work. Interestingly, melatonin has very powerful anti-inflammatory properties. It blocks interleukins, so that might be helpful. And also, interestingly, binds to ACE2. And so that might be a mechanism by which melatonin can actually impair the virus's ability to access the CNS system. We also see that people who take melatonin, they actually decrease beta amyloid production. So that might have potential to help with brain fog. And it's also been shown to decrease the tachycardia of POTS. So for people with long COVID, maybe this is an option. It's relatively easy to try. And relatively devoid of toxicity, but again, not well studied, but I think has some potential and I think is worth some exploration. There's another drug called prazosin. This is what's called an alpha-1 blocker. This medication is used for hypertension, but also used to treat nightmares and PTSD. So we see that one of the things that happens with COVID, especially in people who had significant immune problems, they have excess cytokine release, but that requires the alpha-1 receptor to kind of continue that cascade. So if it's used acutely in a COVID-19 infection, it might actually prevent the acute respiratory distress and might have a role to decrease the inflammatory response effects that occur in long COVID. So may also be a reasonable medication to consider. So just in terms of symptomatic relief, maybe looking at stimulants or wakefulness agents like Ritalin and related drugs, amphetamine drugs. So these are used for ADHD and narcolepsy. They increase the availability of norepinephrine or dopamine, two brain chemicals that are very important for alertness and vigilance and energy. And when these medications are used in CFS and POTS patients, there is evidence of some benefits. So that may have some potential for long COVID as well, maybe just for some symptomatic relief for those patients. There's also a group of agents that I just grouped as gamma aminobutyric acid or GABA agents. So the most powerful one of these is called sodium oxybate. It's called a GABA-B agonist. So GABA is a main inhibitory brain chemical in our body that just suppresses everything that we have. About 70% of our brain chemicals are actually GABA. So this sodium oxybate is actually used for patients with narcolepsy, with cataplexy. So narcolepsy is a disabling disorder of excessive daytime sleepiness accompanied by spells called cataplexy. But what's really interesting about sodium oxybate, there are studies showing that this actually decreases the alpha delta seen in fibromyalgia and CFS and also increases deep sleep. And in at least 4 studies was shown to significantly improve pain and fatigue in CFS and FM patients. So the company that made this tried to advocate for this, for coverage for those pain conditions, but the FDA actually denied their application. They voted 20-2 against the use of sodium oxybate for fibromyalgia, not because of the efficacy though. Everybody actually had concerns about the toxicity because it can have significant adverse effects, respiratory suppression, confusion. It also has very powerful amnestic effects. So there are cases of people abusing this as a date rape drug. So for narcolepsy, it's very carefully controlled because of these issues. But again, it may have potential, I think, for the long COVID patients. And lastly, I want to talk about the serotonin drugs. So in major depressive disorder, one of the curious things about depressive disorder is that, why is it that when we administer these drugs, it doesn't work instantly? Anyone who prescribes these knows that you have to counsel patients. It takes 4 to 6 weeks before you might see a response, even though the effects on serotonin actually occur fairly quickly. And some people believe that it might be related to the effects on inhibiting cytokine production, and depression for a lot of people may be linked to increased inflammation and permeability of the brain tissue to these inflammatory molecules. We already use SSRIs to treat fibromyalgia. And what's really interesting with these drugs is in other studies looking at hospitals, mental health hospitals, those patients who are on antidepressants or general hospitals actually had an 89% lower risk of death compared to what is expected for the same number of people who were infected by COVID. I mean, just as an anecdote, like at the Royal, where I work, which is a mental health hospital, I was surprised at how few outbreaks we had compared to like the Ottawa hospital. Now, part of it is like, obviously they get more severe patients, but a lot of patients at the Royal, they're on antidepressants. And some people speculated that when they saw patients who are on antidepressants, they actually don't get as many of the COVID symptoms, suggesting that maybe the antidepressants are imparting a protective effect. So anyways, just to conclude, I feel confident that long COVID is real. We think it'll probably affect 1.4 million Canadians. The mechanism is really poorly understood. There are probably multiple causes. Sleep mechanisms, they might be involved in some of the symptomatology. So if that's the case, then sleep medication interventions have potential to be helpful, but I can't stress that enough. None of these have been really well study, but I think this is another avenue of research that's needed to be explored to get some different ideas to try to treat this condition. So thank you for your attention. Okay, and I'm happy to take any questions, but I don't know who's who's here.
So for the questions, for those that are in the chat, there's a Q&A option on the top. And if you guys have any questions, we can ask Dr. Lee right there and we'll read them up for you. Is there anyone in the room?
Sure. Most of them do, yes. Melatonin does not. Yeah. Melatonin is available over the counter to take. So there are some concerns about the purity of melatonin when you take it over the counter because it's not regulated by Health Canada like prescription medications. But I found out yesterday that all of there are recent rules passed by Health Canada that require that if you have something called an NTN number, I think, on the bottle, which I think you can look at, if it has an NTN number, then the product, the purity of the product is actually guaranteed, which otherwise is not the case if they don't have that number. So people could put anything in there. And there was a fairly recent, highly publicized study out of Guelph showing that the variance can be like from 2% to 400% of the active ingredients, which is crazy how much or how little they can put in the product. So, right, but otherwise, so that Weber brand I think is a very common brand, and so I think that's the one I'd recommend for people. And it's not clear, even if melatonin has potential because of theory, like what's the dose you should take? Is it 1? Is it 3? 10? We don't really know. I will say the amount of melatonin in our brain is like 0.3 milligrams. So even 1 milligram is like way more than our brain needs. So it shouldn't be more than that's what I see people taking these mega doses of 20, 30 like milligrams. That's crazy to use. Normally, you don't need any more than 3 milligrams for our routine purposes, except for maybe some of the sleep conditions. So the melatonin sold in doses of 1, 3, 5, 10. I think there's a 10. And then there's like under the tongue, long acting, short acting. So, but commonest doses are usually 3 and 5 that people can find.
We got one question from Felix in the chat, and he says, "Hi, are there any lifestyle practices you could speak on to help boost quality of sleep?"
Oh, that's a great question. So really, I heard an interesting talk yesterday, first of all, suggesting that people who are short sleepers might have an increased risk of developing long COVID. So the first thing would be actually maybe to prioritize your sleep and try to get a reasonable amount of sleep. So for most people, that'll be 7 to 9 hours of sleep at night. So if you're short on sleep, I guess that's the first thing to prioritize that. So otherwise, important tips to kind of help you with your sleep, general things. I think the number one thing that we could suggest is try to go to sleep and wake up at the same time every day. Particularly the wake up time is the most important, to keep that the same. Our body's very strongly influenced by our own circadian rhythms. So to keep that wake up time the same, and then to make sleep a priority. Prior to going to sleep, really having good sleep habits. So have a good wind down routine, usually an hour or two before bed, to try to get rid of phones from the bed, any kind of work issues. The bed should only be for sleep or intimacy, like not for doing work or other things or staying awake too long in bed. Avoiding other things that can compromise sleep. We know, like alcohol, cannabis, all these other things that we hear about sleep. Also try not to nap in the day. Try to get 16 hours of wakefulness in the day. So if you nap too much in the day, then that reduces the pressure or drive you have to sleep at night. So sleep is a really funny thing. the harder you try to sleep, the worse your sleep is. And so, you know, if it's important to like get rid of the clock in the bedroom. If you look at the clock, then it makes you think about your sleep more. So this would be another thing that could be really helpful. Just don't look at the time in the middle of the night. Just associate the bed only with sleep. There are many other things that people can use, but those are some of my common tips that I suggest for people, especially in the beginning.
All right, well, I think let's thank Dr. Lee again for that amazing presentation on long COVID, and we hope you enjoyed that as well. And again, thank you for listening, and you're open to stage for the next talk. We'll be setting up in a couple minutes and beginning around